CBCT, Applications in Endodontics. Foundations of CBCT Interpretation. Radiographic imaging is the absolute cornerstone of endodontic therapy because it provides essential information that is unobtainable through clinical examination alone. In daily practice, intraoral radiography serves as our foundational diagnostic tool and is officially considered by the AAE as the modality of choice for initial evaluation. However, as we advance our clinical skills, we must recognize when 2D imaging falls short. While periapical radiographs are excellent for routine screening, they compress complex three-dimensional anatomy into a single flat image. The role of CBCT in endodontics is to step in when standard imaging leaves us with unanswered questions, providing the clarity needed to formulate a sound treatment plan during the preoperative, intraoperative, or postoperative phases of patient care. The fundamental limitation of traditional intraoral radiography is that it creates a geometric projection, resulting in the superimposition of anatomical features. Dense structures like the zygomatic process or a large palatal root can completely obscure underlying pathology or mask the true complexity of apical anatomy. Cone Beam Computed Tomography fundamentally overcomes these limitations by acquiring volumetric data to provide a geometrically accurate, true three-dimensional view. By eliminating distortion and anatomical superimposition, clinical studies have consistently demonstrated that CBCT is significantly more sensitive and accurate for identifying key conditions. This unparalleled accuracy applies directly to diagnosing periapical pathosis, locating missed canals, and evaluating root resorption, giving clinicians a distinct advantage in challenging cases. Despite its incredible diagnostic power, the decision to prescribe a CBCT scan must never be taken lightly. Its use in endodontics is strictly guided by joint position statements from the AAE and the AAOMR, which emphasize the fundamental principle of justification. This means that for every single patient, the clinician is responsible for weighing the potential diagnostic benefits of the scan against the potential risks of additional radiation exposure. There must be a clear clinical expectation that the 3D volume will provide vital information unobtainable from conventional 2D radiography, and that this new information will meaningfully impact your treatment plan or the patient's prognosis. CBCT is a highly specialized complementary tool reserved for specific and complex clinical situations, and it should never replace standard intraoral radiography for routine, uncomplicated cases. To maximize the diagnostic yield of your CBCT scans while adhering to radiation safety protocols, it is crucial to carefully select your technical scan parameters. The most important principle, heavily guided by the American Association of Endodontists, is to always utilize a limited or focused field of view. This means you must collimate the scan so that it includes only the specific tooth or teeth of interest. Utilizing a limited field of view provides two massive clinical benefits. First, it significantly reduces the patient's overall radiation dose, strictly adhering to the ALARA principle. Second, capturing a smaller scan volume drastically reduces scatter radiation, which in turn dramatically improves the overall image quality and contrast, making it much easier to spot subtle endodontic pathologies. In addition to selecting a limited field of view, capturing high-quality endodontic imaging relies heavily on understanding and choosing the correct voxel size. A voxel represents a value on a regular grid in three-dimensional space, essentially acting as the 3D equivalent of a 2D pixel. When interpreting endodontic anatomy, we are often looking for microscopic details, such as accessory canals, microfractures, or subtle changes in the periodontal ligament space. Therefore, we must use a smaller voxel size, typically ranging from 0.076 to 0.125 millimeters, to achieve the necessary higher spatial resolution. This smaller voxel size ensures that the finer anatomical details required for precise endodontic diagnosis are clearly visualized and not blurred out by insufficient resolution. Acquiring the CBCT scan is only the first step. Arriving at an accurate diagnosis depends entirely on proper interpretation, which absolutely must begin with correctly orienting the image data. When you open a scan, the software initially presents the tooth from three standard orthogonal planes: the axial, sagittal, and coronal views. However, because teeth naturally sit at an angle and are often tilted in the jaw, these standard views rarely align with the true long axis of the tooth. Viewing a tooth at an improper angle is dangerous because it can create diagnostic illusions, leading to an undercall where you miss an existing disease, or an overcall where you mistake an artifact for true pathology. It is absolutely imperative that your first step in software manipulation is to reorient the viewing planes so they are perfectly aligned with the true long axis of the tooth in question. The true power of Cone Beam Computed Tomography lies in its software, which gives us the ability to view dental anatomy in nearly unlimited ways. During your interpretation process, it is vital to utilize the different viewing planes to construct a complete three-dimensional mental model of the tooth. For endodontic applications, the axial view is particularly powerful and should be heavily utilized. The axial view provides a cross-sectional, bottom-up slice of the tooth, as if you were looking directly down into the root canal system from the crown. By systematically scrolling through these axial slices from the crown all the way down to the radiographic apex, you can continuously trace the entire course of the root canal. This process allows you to definitively identify the exact number of canals, visualize where they might split or join, and diagnose complex morphologies like C-shaped canals. Beyond simply relying on the standard orthogonal planes, advanced CBCT software allows clinicians to create completely customized viewing angles. The foundational custom view is reorienting the image data to be perfectly aligned with the tooth's true long axis, regardless of its natural tilt. This custom long axis view provides the most diagnostically accurate perspective for evaluating critical structures, such as the periodontal ligament space and the boundaries of the root canal. Furthermore, we can utilize advanced features to create custom cross-sectional sections. Once the long axis is established, you can generate a series of slices that spin around the tooth in a full 360 degrees. This spinning capability allows you to examine every single point on the root surface from a perfectly perpendicular angle, making it an invaluable technique for spotting subtle fractures, identifying lateral perforations, or pinpointing the exact location of resorptive defects. While Cone Beam Computed Tomography is an incredibly powerful diagnostic tool, we must approach image interpretation with a clear understanding of its limitations. CBCT images are highly susceptible to various artifacts that can severely degrade image quality and ultimately complicate or even prevent an accurate diagnosis. In endodontic imaging, the most common and troublesome artifacts you will encounter are beam hardening and streaking. These visual distortions are caused by the X-ray beam passing through highly dense materials such as metal posts, gutta percha, or amalgam restorations. As the beam passes through, its energy spectrum changes, projecting dark or bright streaks across the image. You must evaluate these areas cautiously, because these artifacts can completely obscure the underlying root anatomy, or worse, perfectly mimic the dark, linear appearance of a vertical root fracture, potentially leading to a devastating misdiagnosis. To combat the severe diagnostic challenges posed by dense metallic restorations and root canal filling materials, many modern CBCT scanners come equipped with specialized software algorithms known as metal artifact reduction, or MAR. When activated, this software performs complex mathematical calculations on the raw scan data to specifically identify and reduce the disruptive dark streaks and bands caused by beam hardening. In the majority of clinical cases, applying MAR significantly improves the overall image quality around metallic restorations, allowing you to much more clearly visualize and interpret the adjacent root anatomy and surrounding bone. However, it is absolutely critical for clinicians to understand that MAR is not a perfect magic solution. It does not eliminate artifacts completely, and the aggressive algorithmic correction can sometimes introduce new, more subtle distortions into the image, meaning you must still evaluate the area with a highly critical eye. Preoperative anatomy and pathosis. When evaluating a tooth for endodontic disease, recognizing the specific pattern of bone destruction is key to making an accurate radiographic diagnosis of periapical periodontitis. The inflammatory process, initiated by necrotic pulp tissue, first affects the immediate periapical tissues. When reading the CBCT, you should systematically evaluate the root apex. Radiographically, the earliest sign you will see is a widening of the periodontal ligament, or PDL space, right at the apex of the affected root. As the lesion progresses and the inflammation becomes more severe, it causes resorption of the lamina dura, which is the thin, distinct cortical bone that lines the tooth socket. The resulting radiolucency is characteristically centered on the apex, or a portal of exit of the root canal system. Identifying this specific combination, a widened PDL, lost lamina dura, and a centered lesion, confirms your diagnosis. One of the most challenging clinical scenarios in endodontics is a patient who presents with vague, nonspecific, or referred pain. In these cases, clinical testing and 2D radiographs often fail to definitively identify the source of the problem. The patient may point to an entire quadrant, or the clinical signs may be completely contradictory, with no clear evidence of pathology visible on the standard periapical images. This is a primary indication for a limited FOV-CBCT scan. When you interpret the 3D volume, carefully scroll through the slices to strip away the anatomical noise. By providing a three-dimensional view, CBCT can often reveal subtle or early periapical lesions that were completely hidden on the 2D radiograph due to the thickness and density of the overlying cortical bone. Finding this hidden pathology allows you to pinpoint the exact offending tooth, confidently make a diagnosis, and save the patient from unnecessary procedures on healthy teeth. The long-term success of endodontic therapy is predicated on the complete debridement, disinfection, and obturation of the entire root canal system. Consequently, the failure to locate and treat all canals is one of the most common reasons for post-treatment disease. When planning your access cavity, CBCT is an exceptionally powerful tool for identifying the presence of additional canals before treatment even begins. While standard 2D radiographs might offer subtle clues, CBCT provides a definitive view. To find these hidden canals, you must shift your focus to the axial plane in your software. As you scroll down the long axis of the root, you are looking for the geometric position of the canal space within the root structure. This evaluation in the axial slice is the secret to discovering extra anatomy that would otherwise be missed clinically. To reliably identify a missed canal, such as the notorious MB2 in a maxillary molar, you must learn to read the geometry of the root in the axial plane. When interpreting the CBCT, find the root in question and look at the axial cross-section. A root with a single canal will normally have that canal space perfectly centered within the surrounding dentin. However, if the canal space appears to be offset to one side, for example, shifted heavily towards the mesial or buccal, it is a strong, highly reliable indication that an additional, untreated canal is present within that same root. When looking at the mesio-buccal root of a maxillary molar, observing this offset positioning is the classic sign used to confirm the presence of the MB2 canal. When evaluating mandibular molars, you must actively look for the presence of a supernumerary root, most commonly the radix antemolaris. This extra root is located on the distolingual aspect of the tooth and is notoriously difficult to identify on standard 2D radiographs due to severe superimposition over the main distal root. On your CBCT scan, you will shift your focus to the axial plane. As you scroll apically from the cemento-enamel junction, Look carefully at the overall root structure. A radix antemalaris will appear as a distinct, separate root mass branching off toward the lingual side. Identifying this extra root preoperatively is absolutely critical, as it dictates a necessary modification to your access cavity preparation. You will need to extend your access further to the distolingual to safely locate and instrument this additional canal system. Beyond simply counting the number of canals, your preoperative CBCT assessment must evaluate their internal shape or morphology, which can be highly variable and complex. Understanding this morphology preoperatively is crucial for effective and safe instrumentation. As you scroll vertically through the axial slices, pay close attention to how the canal walls behave. Canals frequently diverge and converge in various unpredictable ways. CBCT can clearly show common but complex variations, such as canals that start as two separate orifices at the chamber floor, merge into a single canal mid-root, and then split again into two separate exits at the apex. This specific 2-1-2 configuration is nearly impossible to discern from a 2D radiograph, but with CBCT, you can map the exact millimeter marks where these merges and splits occur. One of the most challenging anatomical variations you will encounter is the C-shaped canal, most commonly found in mandibular second molars. Attempting to instrument this type of anatomy without being aware of its presence preoperatively can easily lead to incomplete cleaning or severe procedural errors. When interpreting the CBCT, you will not see distinct round orifices. Instead, this variation appears on an axial CBCT slice as a continuous ribbon, or C, of canal space that seamlessly connects the mesial and distal aspects of the root. As you scroll apically, this C shape may change, divide, or merge. Carefully tracing this continuous ribbon on the axial view is the only way to fully grasp the 3D complexity of the finned and webbed areas that you will need to clean chemically, as rotary files cannot effectively shape a ribbon-like space. Pulp stones or denticles are discrete calcified masses found within the pulp chamber or the root canal space. While often an incidental finding, large pulp stones can present a significant clinical challenge during endodontic treatment by physically blocking access to the canal orifices. On your CBCT scan, they will appear as distinct, well-defined hyperdense structures within the pulp space, demonstrating a radiopacity similar to the surrounding dentin. While they may be somewhat visible on a standard 2D radiograph, a CBCT provides a precise three-dimensional location of the stone relative to the pulp chamber floor and the expected position of the underlying canal orifices. When reading the scan, you should measure the exact depth and width of the stone. This information is invaluable, as it allows you to be much more targeted and conservative when attempting to remove or bypass the calcification. Developmental anomalies can significantly complicate endodontic treatment, and one of the most common to look out for is dens in dente, also known as dens invaginatus. Radiographically, this anomaly appears as an infolding of the enamelin dentin, creating the distinct appearance of a tooth within a tooth. Because this invagination creates a deep pit or channel that is impossible for the patient to clean, these teeth are highly susceptible to caries and early pulp necrosis. A 2D radiograph can identify the mere presence of dens in dente, but interpreting a CBCT is absolutely invaluable for determining the full extent and complexity of the invagination. You must use the sagittal and coronal views to trace the entire pathway of the defect and analyze its relationship to the main pulp chamber and root canal system. To summarize our approach to the preoperative phase, the CBCT is not just a picture, it is a critical mapping tool that dictates your clinical workflow. When clinical signs are ambiguous, you use the scan to identify subtle pathology and confirm the true source of a patient's pain. More importantly, it is an unparalleled tool for mapping out complex root canal anatomy and developmental anomalies before your burr ever touches the tooth. By systematically reading the axial slices and custom views, you can confidently find missed canals, navigate challenging C-shaped configurations, manage obstructions like pulp stones, and understand the unique anatomy of conditions like dens in dente. Extracting this level of detailed preoperative information from the scan is absolutely essential for creating an effective treatment plan and for avoiding procedural errors. Dental trauma and fractures. In the realm of endodontics, diagnosing traumatic dental injuries can be incredibly complex, and traditional 2D imaging often fails to provide the complete picture needed for an accurate diagnosis. For this reason, Cone Beam CT is widely considered the standard of care for evaluating any significant injuries. When a trauma patient sits in your chair, a CBCT scan allows for the precise visualization of different types of fractures that are almost always obscured by anatomical superimposition on standard intraoral radiographs. Instead of guessing at the extent of the damage from a single flat angle, the 3D volume allows you to systematically evaluate the teeth, the root structures, and the surrounding bone to build a comprehensive diagnosis. Horizontal and oblique root fractures are a common outcome of traumatic dental injuries, particularly luxation or avulsion injuries to the anterior teeth. On a standard 2D radiograph, the fracture may occasionally be visible as a radiolucent line, but if the X-ray beam is not perfectly parallel to the fracture line, the injury can be easily missed. When interpreting the CBCT, you must utilize the software's ability to view the tooth from any angle. By manipulating the custom cross-sections, you can tilt the viewing plane to align directly with the suspected fracture plane. This specific manipulation is what makes CBCT far more sensitive for detecting these subtle horizontal breaks. Similar to strictly horizontal fractures, oblique fractures require you to carefully evaluate the severity of the break. As you scroll through the oriented scan, the CBCT will show you the exact location, orientation, and severity of the oblique fracture. As a clinician, you are specifically looking to see if there is any displacement or separation of the coronal and apical fragments. You must measure the gap and assess how much root structure remains intact. Extracting this highly detailed geometric information from the scan is absolutely critical for determining the tooth's long-term prognosis and for making definitive treatment decisions, such as whether it is viable to attempt splinting or if you must proceed with extraction. Vertical root fractures are longitudinal fractures that typically initiate deep in the root and propagate coronally. You must be aware that they are notoriously difficult to diagnose, both clinically and radiographically. When hunting for a vertical fracture on a CBCT, realize that directly visualizing the actual fracture line can still be very challenging. The fracture itself is often a microscopic separation. Unless the fragments are displaced, the physical line may not be visible even with high-resolution small voxel scans. Furthermore, your diagnosis is made significantly more difficult in previously endodontically treated teeth, as the presence of streaking and beam hardening artifacts from gutta percha and sealer can easily obscure the root surface or falsely mimic a fracture line. Because directly visualizing the microscopic separation of a vertical root fracture is so frequently impossible, you must shift your diagnostic strategy. In practice, the diagnosis of a vertical root fracture is most often made by identifying its secondary signs, which refers to the highly specific pattern of bone loss it creates. As bacteria chronically leak out along the entire longitudinal length of the fracture line, they create a unique, predictable pattern of inflammation and localized bone resorption in the adjacent periodontium. When evaluating the scan of a highly suspect tooth, train your eye to stop looking exclusively at the dentin and start heavily analyzing the topography of the surrounding alveolar bone. When analyzing the surrounding bone for those secondary signs, the classic radiographic indicator of a vertical root fracture is a J-shaped, teardrop, or halo-like radiolucency. As you scroll through your coronal and sagittal slices, look for a deep, isolated pocket of bone loss that runs vertically up the side of the root. This specific pattern physically traces the path of the fracture, moving from the apex directly up towards the alveolar crest. While finding this J shape is a very strong indicator, you must be cautious during interpretation, as it can sometimes be difficult to radiographically differentiate from a deep, narrow, isolated periodontal pocket. Therefore, thorough clinical probing must always correlate with your CBCT findings to make a definitive diagnosis. In cases of severe dentoalveolar trauma, your CBCT interpretation must expand beyond just the tooth structure, as the injury can also involve a fracture of the surrounding alveolar process. To identify an alveolar fracture, you should trace the cortical bone that makes up the tooth socket on your cross-sectional views. You are looking for a clear discontinuity, a step-off, or a visible displacement of the buccal or lingual cortical plates. A 2D radiograph may faintly suggest a bone fracture, but only a volumetric CBCT scan can definitively show the true extent, severity, and displacement of the fractured bone segments in all 3 dimensions. Alongside mapping the fractured bone segments, the CBCT provides a complete and highly accurate picture of any associated tooth luxation. As you review the axial and sagittal planes, you can clearly see the precise direction and the specific degree of the tooth's displacement. You must assess exactly how the root has moved within the socket space, whether it has been intruded, extruded, or laterally displaced, and check if the displaced root apex is impinging on any adjacent vital structures. This dual assessment of both the bone and the tooth's spatial relationship is the critical data gathering needed to safely manage the trauma. Ultimately, taking the time to extract this comprehensive 3-dimensional diagnostic information from the CBCT is paramount for determining the prognosis and formulating an appropriate, effective treatment plan for the traumatized patient. The scan dictates your clinical steps. It provides the exact 3D roadmap needed if the treatment typically involves repositioning a displaced bone segment and splinting it to stabilize the teeth. Conversely, it provides the definitive evidence needed if a severe vertical root fracture renders the tooth hopeless. In short, CBCT provides the complete view of the alveolar fractures and tooth displacement necessary to manage these high-stress clinical situations predictably. Root resorption and pathological mimics. Root resorption is a complex pathological process that presents significant management challenges. A critical first step in your interpretation is to correctly diagnose the specific type of resorption occurring, as the clinical prognosis varies dramatically. On a standard 2D radiograph, the superimposition of surrounding tooth structure makes it extremely difficult to differentiate between internal resorption, which originates within the canal, and external resorption, which attacks the outer root surface. When reading a CBCT, your goal is to utilize the 3D view to pinpoint the exact location of the resorptive defect. By scrolling through the axial and sagittal planes, you must determine its portal of entry and assess its true structural extent, which are the absolute key factors in making an accurate differential diagnosis. External inflammatory root resorption is an infection-driven process most commonly seen as a complication following traumatic injuries, like tooth luxation or avulsion. When assessing a traumatized tooth on CBCT, carefully trace the external root perimeter. Radiographically, you are looking for irregular, scalloped, or scooped-out areas of radiolucency directly on the external root surface. You will also frequently notice an adjacent periapical lesion associated with this defect. Because this destructive process is entirely dependent on the inflammatory stimulus from a necrotic pulp, accurately identifying these external, scooped-out defects allows you to confidently diagnose the condition and plan for timely endodontic intervention to arrest the destruction. Replacement resorption, commonly referred to as ankylosis, occurs when severe trauma causes extensive cellular death to the periodontal ligament. When evaluating the CBCT of a suspected ankylosed tooth, your primary focus must be on the PDL space. The hallmark radiographic sign of replacement resorption is the complete absence of this dark PDL line. On your cross-sectional slices, look closely at the bone-to-tooth interface. You will see the direct fusion of the surrounding alveolar bone directly to the root surface. As the root is slowly resorbed and replaced with bone, it takes on a highly characteristic, moth-eaten appearance. Recognizing this definitive fusion on the scan is critical, as it confirms a poor long-term prognosis where the tooth structure will ultimately be lost. Invasive cervical resorption is a particularly aggressive and often insidious type of external resorption that requires careful CBCT analysis. When interpreting the scan, focus your attention on the cervical third of the root, typically just below the epithelial attachment. Radiographically, this lesion appears as an irregular, asymmetrical radiolucency that also exhibits a moth-eaten appearance. A key interpretive step is to trace the defect inward. You will often see it spread widely through the dentin, while initially leaving the root canal space completely untouched. CBCT is absolutely essential here, as scrolling systematically through the slices is the only way to determine the true three-dimensional extent of the lesion to decide if the tooth is structurally restorable. Unlike the external variants, internal root resorption is an inflammatory process initiated by cells completely within the pulp space. When reviewing your axial and sagittal CBCT slices, the key radiographic feature you must identify is a uniform, smooth, and well-defined oval-shaped enlargement of the root canal space. To definitively diagnose internal resorption and differentiate it from external resorption, you must carefully trace the outer perimeter of the root. On the CBCT, the defect will be clearly contiguous with the inner canal walls, while the external root surface will remain perfectly intact. Confirming this intact external boundary is crucial, as it indicates the process can often be successfully managed with standard endodontic treatment. When interpreting CBCT scans of the posterior maxilla, you must always evaluate the close anatomical relationship between the roots of the maxillary teeth and the floor of the maxillary sinus. Because the apices of these posterior teeth often sit intimately close to the sinus cavity, dental infections can easily cross this boundary. When a maxillary tooth becomes necrotic, the resulting periapical inflammation can rapidly erode the thin cortical bone separating the root apex from the sinus floor. During your radiographic assessment, you must carefully scroll through the sagittal and coronal planes to inspect the integrity of this bony floor. Recognizing this anatomical proximity is the crucial first step before you can accurately identify any subsequent sinus membrane inflammation caused by an infected tooth. Once the thin bone of the sinus floor is breached, inflammatory products enter the sinus cavity and cause a localized reaction in the sinus membrane, resulting in maxillary sinusitis of endodontic origin. To diagnose this on a CBCT scan, you must look for a very specific radiographic presentation. Focus your attention on the soft tissue lining the sinus floor immediately above the suspected tooth. Odontogenic sinusitis classically presents as a distinct dome-shaped or halo-like localized soft tissue density. The most critical diagnostic feature you are looking for is that this thickening is centered directly over the apex of the offending infected tooth. Recognizing this localized, centered pattern is crucial because this specific type of sinusitis will only resolve once the underlying dental infection is properly treated. While we actively look for dental causes of sinus issues, we must remember that sinusitis is a common disease worldwide and frequently arises from non-odontogenic causes like allergies or upper respiratory infections. This creates a significant diagnostic dilemma because the clinical symptoms, such as pressure and pain in the cheek, can perfectly mimic the symptoms of a severe toothache. When reviewing the CBCT, you must differentiate the patterns. Unlike the localized, dome-shaped mucosal thickening seen with dental infections, non-odontogenic sinusitis typically presents as a more generalized thickening of the entire sinus membrane. You may also notice fluid levels or blockage of the main drainage pathways. Recognizing these broader radiographic signs helps prevent patients from being treated unsuccessfully for dental issues when they actually require medical management. During your radiographic interpretation, you must remain vigilant for benign cysts and tumors that can occur in the jaws and perfectly mimic a lesion of endodontic origin. On a standard 2D image, these lesions are often superimposed over the apices of teeth, causing confusion. However, when you evaluate the CBCT volume, you can identify key differentiating features. Unlike a typical inflammatory endodontic lesion, which usually has ill-defined borders, benign cysts typically exhibit very well-defined corticated borders that appear as a distinct radiopaque line. Furthermore, as you scroll through the planes, you will frequently notice that the epicenter of a benign lesion is not actually centered on a tooth apex, and the surrounding lamina dura may remain completely intact. Always correlate these distinct radiographic borders with your clinical vitality testing. Although rare, it is absolutely critical to remember that malignant tumors can present in the jaws, and their early radiographic signs can dangerously mimic endodontic pathology. When interpreting a CBCT, if you notice irregular widening of the PDL space and destruction of the lamina dura, you must look closer. Malignancies often provide subtle clues of a more aggressive process. The bone destruction typically appears highly irregular, invasive, or severely moth-eaten. Additionally, the asymmetric PDL widening might affect multiple adjacent teeth rather than just one. A massive red flag during your assessment is finding significant irregular bone loss on the CBCT around teeth that still remain perfectly vital to clinical pulp testing. Identifying these highly suspicious radiographic features on a CBCT is critical for differentiating malignancy from simple inflammation and ensuring immediate referral. Intraoperative and postoperative assessment. During an active endodontic procedure, several sudden complications can arise that are exceptionally difficult to manage with 2D imaging alone. An intraoperative CBCT scan can serve as a powerful adjunct in these high-stress situations when standard imaging leaves you guessing. As a clinician interpreting this mid-treatment scan, your focus shifts to immediate problem-solving, such as mapping the specific location of severely calcified canals, pinpointing iatrogenic root perforations, or analyzing the 3D position of separated instruments. By taking this focused scan, you transition from blindly searching to precisely navigating the anatomy, allowing for a much more targeted and conservative approach that prevents unnecessary removal of tooth structure or further iatrogenic damage. One of the most common and frustrating challenges in clinical endodontics is attempting to locate the orifice of a severely calcified root canal. When a canal becomes so constricted that it is no longer visible on a 2D radiograph and cannot be found clinically, blindly drilling with a burr carries a massively high risk of creating a root perforation. Taking a limited FOV CBCT intraoperatively allows you to systematically scroll through the axial slices to hunt for the residual canal space. When reading the scan, you are looking for the faint, microscopic outline of the sclerotic canal within the dentin mass. This faint, radiolucent dot provides a precise geometric target for you to aim for with your ultrasonic tips, significantly reducing the risk of procedural errors. While intraoperative CBCT is an incredible tool for finding that initial target, you must approach the interpretation of sclerotic roots with realistic expectations. Even with the advanced, high-resolution, and small voxel size of a CBCT, completely calcified canals can still be exceptionally challenging to see. As you scroll apically through your axial and sagittal views, pay close attention to where the faint canal outline disappears and reappears. If the canal space is completely obliterated by tertiary dentin, with absolutely no radiolucent pathway visible on the scan, the CBCT is telling you that further deep excavation is highly dangerous. Interpreting this complete absence of space is just as critical as finding a canal, as it guides you to stop drilling and reconsider your treatment options before an irreversible error occurs. An iatrogenic root perforation is a highly stressful procedural error where an artificial communication is created between the root canal system and the surrounding periodontal tissues. Because these complications severely impact the long-term prognosis of the tooth, accurate diagnosis is paramount. On a 2D radiograph, a perforation may faintly appear as a deviation of the canal path, but they are notoriously difficult to see, especially if they occur on the hidden buccal or lingual root surfaces. When interpreting an intraoperative CBCT for a suspected perforation, you must utilize the spinning custom cross-sections to trace the entire root perimeter. You are actively looking for a distinct break or discontinuity in the outer root surface. The 3D volume will definitively identify the exact size, shape, and three-dimensional location of this defect. Once you have identified the precise location of the perforation on the CBCT scan, you must use that radiographic data to dictate your clinical repair strategy. Knowing the exact spatial orientation, whether the perforation is located coronally or apically, and whether it exits on the mesial, distal, buccal, or lingual surface, is absolutely critical information. By measuring the diameter of the defect on the scan and analyzing the surrounding bone level, the CBCT guides your direct decision-making process. This specific radiographic interpretation tells you how accessible the defect is, dictating both the specific bioceramic material you should choose and the physical delivery technique required to achieve a successful, long-lasting seal. The separation of an endodontic rotary file or hand instrument within the root canal is a significant complication that requires careful radiographic analysis before attempting any retrieval. Radiographically, the separated instrument will appear as a distinct, intensely hyperdense and radio-opaque object lodged within the canal space. While a standard 2D radiograph might show the general location of the fragment in a flat mesial distal dimension, a CBCT provides vastly more specific and crucial information. When reading the CBCT, you must evaluate the fragment's precise position in the buccolingual dimension and, most importantly, visualize its exact relationship to any severe curvatures in the root canal. This specific 3D spatial information is absolutely critical for helping the clinician understand the true feasibility of the retrieval procedure and calculating the exact amount of surrounding dentin that would need to be safely sacrificed to grab the file. The final and arguably most important phase of treatment, where imaging plays a critical role, is the postoperative assessment. This phase involves both the immediate evaluation of your obturation quality and the long-term follow-up to monitor the healing of the periapical tissues. While standard 2D periapical radiographs typically remain the baseline standard for routine recall appointments, CBCT becomes a highly valuable and necessary tool in specific situations where questions, persistent symptoms, or complications arise. The primary indications for ordering a postoperative CBCT include the need for an objective evaluation of questionable or incomplete healing of a periapical lesion, or when a patient remains surprisingly symptomatic despite a seemingly perfect 2D radiograph. When evaluating recall patients, you must understand that 2D intraoral imaging can frequently overestimate true endodontic healing. A periapical lesion may appear to have completely resolved on a standard radiograph simply because the dense buccal and lingual cortical plates of bone have remineralized, even if a significant radiolucent defect still actively exists hidden within the cancellous bone. To get a more objective assessment of osseous changes, you must read the CBCT volume. Radiographically, true healing on a CBCT scan will exhibit two distinct features: a clear, measurable reduction in the overall volumetric size of the radiolucency in all three dimensions, and definitive evidence of new bone formation. This new bone typically appears as a diffuse, somewhat disorganized pattern of bone production that radiates inward from the periphery of the lesion. When a previously treated tooth presents with persistent or recurrent apical disease, a CBCT scan is absolutely invaluable for identifying the true underlying cause of the failure before you initiate retreatment. The 3D images can clearly reveal etiologic factors that are almost always invisible on 2D radiographs. When interpreting a failure case, systematically check for common culprits. Carefully scroll through the axial plane to look for missed and entirely untreated canals. Evaluate the density and length of the existing obturation, and look closely for complex or unusual anatomy that was not properly managed during the initial therapy. By providing a definitive, visible reason for the failure, interpreting the CBCT helps you make a crucial clinical decision, whether to attempt advanced, non-surgical retreatment or to proceed directly to a surgical approach. For complex failure cases that definitively require periradicular surgery, such as an apicoectomy, interpreting a preoperative CBCT scan is now widely considered an essential standard of care for safe and predictable surgical planning. The CBCT provides the surgeon with a highly precise, three-dimensional roadmap of the surgical site. As you review the scan, you must accurately visualize the exact volumetric size and extent of the periapical lesion and carefully examine the specific morphology of the root apex that needs to be resected. Most critically, you must use the software's measurement tools to assess the exact proximity of the root apices to adjacent vital anatomical structures. Knowing the precise millimeter distance to the inferior alveolar nerve canal, the mental foramen, or the floor of the maxillary sinus allows the surgeon to confidently plan the osteotomy and minimize any risk of devastating iatrogenic injury.